drop me a message in the chat. So I'm Katrina, I'm the events coordinator for BUSOG events, and this is our fourth webinar. Thank you so much for everybody who's joining us for the first time or joining us again. We've had such amazing interest this semester, and we're quite happy to be finishing with this webinar in 2020. So this time we'll be discussing pregestational diabetes, and we've got two wonderful speakers with us. Just before I introduce the speakers, some housekeeping, which I'm sure you all know. If you would keep your cameras and your microphones off, that'd be much appreciated. We use Slido for question links, and these will be posted in the Zoom chat for each speaker, and we'll have a structure of a talk followed by Q&A for each speaker. And finally, if you've got any feedback for us, we'd be very happy to hear it, and we'll be posting a feedback link at the end of the talk. And also, if you would like to access the certificate, you will have to fill in this feedback form, and I will stay behind and sort out any issues for you at the end as well. So without further ado, I'll introduce our speaker tonight, Dr. Matthew Coleman. So Matthew works in the Southampton Trust, and alongside his role as a consultant in fetal and maternal medicine, Matthew is the current lead for maternal and fetal medicine, and he's the president of McDonald UK Maternal Medicine Society. And in his talk, he'll be sharing insights with us from his extensive experience in managing women with diabetes before, during, and after pregnancy. So I will hand over to you, Matthew.
Great, thank you very much for that introduction, and thank you for the invitation. So I've gone up both career trees in that I did my medical membership and did a bit of obs and gynae, then I did my medical membership, and then I went back into obs and gynae. So I'm kind of doubly trained, and the last few years in particular, I focus on looking after women with background medical conditions. And that's kind of linked in with my presidency at the McDonald Obstetric Medicine Society, which has just come to an end, and a real focus on maternal medicine, including diabetes. And then much more recently, in the last 3 or 4 years, I've really began to think about why we make decisions in medicine and what determines those, because it's not all clear. In fact, the more I think about it and the more I read about it, it's strongly influenced by human factors and bias. And I want to show you a few slides, about half the talk on human factors and bias, and the first bit of the talk on diabetes. So that's where we'll start. As always, I'd welcome questions, interactions. Use Slido, interrupt me if you like, challenge me. The days of just presenting slides and learning facts should hopefully be over. It's about how you apply the facts. It's about how you think. It's about how you work through a clinical problem or a mathematical problem or any problem, rather than learning the facts pro rata, because they're all on your phone. All the facts are now on your phone, immediately available. It's how you apply the knowledge that's going to be the challenge for your generation. So let's get a few slides up. Hopefully you can all see that now. Please, somebody shout if you can't see an orange and green slides talking about diabetes in pregnancy, human factors and bias, and is risk a colour?
We can see that, Matthew, thanks.
Great. So I'm going to save the bandwidth and stop my video. You can still hear me, hopefully. So let's work our way through some of these slides. So as you know, diabetes is a long-term condition. It's probably the most commonest condition that complicates pregnancy. And at the moment, in Southampton, we see about 50 to 60 women with pre-existing diabetes a year, and somewhere between 200 and 300 women with gestational diabetes. So I just want to talk about some of the principles, because if you understand the principles of the background type of diabetes, then the management becomes a lot more apparent and easier. So type 1 diabetes, a lifelong tendency to hypoglycemia after immune-mediated and complete, this is the important bit, complete destruction of insulin producing beta cells. So they have no endogenous insulin. So their swings in sugar are much more pronounced than the women with type 2 or other types of diabetes. They must have insulin. It must be continued through the pregnancy, and there's a number of changes that we might talk about to help maintain glycemia. And sometimes they can have too much insulin, leading to the significant risk of hypoglycemia. And there is some tension in the drive to improve glycemic control and the risk of hypoglycemia. And we're certainly understanding that outside of pregnancy, that the morbidity associated with hypoglycemia can be quite significant. Certainly the morbidity and how it affects the rest of your life. Some people with type 1 diabetes also have insulin resistance, and typically people with type 1 diabetes require significant changes to their insulin volumes as the pregnancy advances. So the insulin resistance of pregnancy affects women with type 1 diabetes as much as it does those with type 2 diabetes, and as much as it does in creating the new, this novel diagnosis of new gestational diabetes. Diet and lifestyle are an important part of type 1 diabetes as much as they are of any diabetes. If women struggle with their diet and are unable to take regular exercise, then their diabetes will be more difficult to control. And it's quite easy for us to forget about adjustments to diet and lifestyle when we focus on adjusting their insulin. Diabetic ketoacidosis is relatively common in this group, typically when their insulin, the insulin that they have is overwhelmed by infection or pregnancy, or they stop taking their insulin because they're vomiting in early pregnancy. So DKA is relatively common, and we've introduced a number of safety netting processes around ketone testing in the last few years to help pick that up, pick ketosis up before it becomes acidosis up at an earlier time. So type 1 diabetes, they have none of their own insulin. They have to take it all. It should never be stopped. They develop insulin resistance like all other women, including those with type 2 and gestational. Type 2 diabetes, on the other hand, is a completely different disease, which is coincidentally has a similar feature of hyperglycemia. This is a disease of insulin resistance and or inaction. They have abnormal glucose metabolism and a whole range of significant other and related metabolic diseases. Most of these women are diagnosed following screening, and that's a similarity with gestational diabetes. And typically this is typically we see hyperglycemia and an elevated glycosylated hemoglobin. Typically there are very few associated symptoms which are inconsistent and unreliable in terms of a screening test. Diabetic ketoacidosis is possible, but much less likely, and certainly much less likely in the population in pregnancy. Again, the treatments are, and again, the main treatment for all people with diabetes is lifestyle, diet and exercise, medications, which outside of pregnancy increase your glucose excretion, or they adjust your peripheral insulin resistance, possibly insulin. But the main driver of type 2 diabetes, the main driver of gestational diabetes, and there's huge overlap between these two, is insulin resistance. So more insulin is, as an anabolic steroid, leads to more weight gain, which leads to more insulin resistance. So there's a bit of a vicious circle there, that introducing insulin, especially to the large women with elevated BMIs, can be counterproductive in the longer term in terms of achieving good glycemic control. In pregnancy, the interventions, as suggested, are lifestyle, metformin, and then insulin. And the outcomes, the risks, are quite similar to those women with type 1 diabetes. And this has been underestimated in the past, because many women with type 2 diabetes don't see their doctor for regular prescriptions. They're just diet controlled outside of pregnancy. They don't have the normal pre-pregnancy discussions and considerations that the type 1 population would have. Gestational diabetes. So this is just like type 2 diabetes in pregnancy. It has all the similar features. Insulin resistance, which starts at about 12 weeks and maxes out at about between 30 and 36 weeks, and then tends to improve slightly towards the end of pregnancy. Screening is important because the symptoms are few and inconsistent, again, very similar to type 2 diabetes. The current screening, NICE and local guidance in nearly all hospitals would use these risk factors for screening: previous gestational diabetes, previous large baby. And again, there's a note here that macrosomia in the current pregnancy is not on the NICE list of recommended screening, and it's certainly not on our guideline in Southampton. First degree family history and ethnicity relating to the underlying genetic predisposition that some families and ethnic groups have. Again, large BMIs and a few others, including some of the antipsychotic medications and antiretrovirals. Depending on your background population and how you test, and I don't want to get hung up in the testing today, you can find that between 15 to 20% of your pregnant population have gestational diabetes. And this relates and causes significant labeling and capacity related issues, from GTTs to where women might give birth, to ultrasound capacity, to clinic capacity. A big challenge for the health service, and one that needs better balance with the testing and with the diagnosis. The management and treatment of gestational diabetes, almost identical to that of type 2, apart from some of the medications used outside of pregnancy are not recommended in pregnancy. So the new glycosomes and nearly all of the newer oral hypoglycemic agents are not recommended in pregnancy. Metformin, good grade A randomized data that suggests this improves outcome, both for the women and for their babies. So a relationship between metformin use and less weight gain, one of the main causes of gestational diabetes, or main associations: less weight gain for the mother and less weight gain for the baby. If metformin doesn't achieve good glycemic control after a trial of diet and exercise and then metformin, then the traditional and typical recommended second intervention is insulin. Regular assessments of fetal growth and a careful thinking about the type and the timing of birth, glucose control in the peripartum period, and then importantly, in an area that we've only recently realized is also important, is the discussions and the recommendations after the birth if you have a pregnancy complicated by gestational diabetes. So there are a number of ways of screening for diabetes after the birth. In Southampton, for convenience, we use a fasting blood sugar within 3 days, and we are able to screen nearly 100% of our population using this method. If you defer the screening until women go home, then the tests might be more slightly more reliable, a GTT at 6 weeks being the traditional one, or glycosylated hemoglobin more typically at about 3 months, then significant numbers of women fail to attend for those appointments for any number of reasons. So we've had great success from fasting blood glucose within 3 days. All the women are captured during their birthing episode. They're all screened, and then depending on the results of that, we recommend annual lifelong screening, a HbA1 a bit sooner than annual if the test is borderline, or if the test is elevated, the fasting blood sugar, a series of continued capillary blood glucose monitoring. The long-term management for women after pregnancy complicated by gestational diabetes is the same as it is for the rest of the population. Diet and lifestyle. The whole population needs to exercise more and eat a less glycemic diet. So this shouldn't come as a surprise, and certainly for the majority of women with gestational diabetes, they are a population that is overrepresented by large size. This shouldn't be news to them, and it is surprising how often it is news, that the diet and lifestyle for them and their children, and it's a great opportunity to influence early life infant and child growth and eating behaviors. The diet and lifestyle continues forever, and they have an annual screen for their diabetes, typically with a HbA1. So why is the major focus in pregnancy on glycemic control? Well, we've thought for many years about the apparent incidence of major abnormalities in the baby. So one of the major risks of uncontrolled glycemia is cardiac defects. And this was a relatively strong study that came from Sweden, where they have fantastic national databases. And it looked at the glycosylated hemoglobin 3 months before or after conception, so in the early pregnancy. And you can, these are the number of events per 1,000 infants of major cardiac defects. And this was only in the live-born, so there may be even more in that women diagnosed with them, whose babies have diagnosed with a major cardiac abnormality, often consider termination of pregnancy. And the line, this is my line, the red line, but there's an apparent direct relationship between the glycosylated hemoglobin in old units and the risk of cardiac defects. And this equates to about 77 extra cases per 1,000 births. And if you draw down from at 9%, which is considered nearly universally to be terrible control, that equates to about 6 times of the background risk, which is illustrated by the dotted line, which comes across about this risk at this level. The other thing to say is that even if your control is excellent, and this is well controlled, with a significant risk that this of hypoglycemia interfering with your lifestyle, with some long-term risk for the mother if you push the control much below 6.5. And we need to come back to that because there are now developed ways around this. So even if you had excellent control, you still had a doubling of the risk. So this this neat study confirmed what we thought. The major risks for the baby relate to miscarriage first in the first trimester, then congenital abnormalities, typically cardiac and neural tubes, so spina bifida, and then in later pregnancy, abnormalities of growth, accelerated growth, the mechanics of delivering a large baby and the risks both for the mother and the baby, and then the metabolic consequences for the baby after the birth. And I want to talk, as I've suggested, of miscarriage, congenital abnormalities, accelerated growth, and the consequences of accelerated growth. The two risks that scare everybody, in particular the mothers and but also the clinicians, are stillbirth and shoulder dystocia. Shoulder dystocia in its true severe form is a terrible condition where the baby's head is delivered and the shoulders become impacted at the pelvic inlet, so quite high in the within the pelvis. It leads to a lot of panic. It's a sudden, unexpected consequences of childbirth, where there's with a high risk of harm to the mother and to the baby, including a fresh and stillborn baby, as a consequence that it can't be delivered in either route. And there's a number of mechanical ways of helping to relieve the shoulder dystocia. Again, I'll leave you to look up about those details. Stillbirth, again, a major and dramatic consequence for the family and for the clinicians involved in the pregnancy. But these two outcomes, I want to carry on with our thoughts into kind of the second half of the presentation, when we come to talk about risk and how we think about risk. So insulin pumps, and as I've alluded to, one of the ways around achieving fantastic control is half of the process is to take better control of your insulin delivery. This is where we were many years ago. This is one of the first insulin pumps, as you can see. Apart from a man in the lab, it's completely useless. This is a slightly out of date pump now. There's a pump which has some controls on it, some tubing that links the reservoir around to a small subcutaneous plastic needle. The principles of pumping, as I think many of you will know, there is a reservoir. This is a picture of a reservoir with a small bubble, because bubbles in any fluid process lead to a degree of inaccuracy. So the reservoir goes into the pump, the tubing comes out and goes round and into the body via a small subcutaneous needle, and these typically last for 2 or 3 days. So rapid insulin is used. We talked about the pump and the subcutaneous needle. So the benefits of this is the fine control of the insulin delivery process. The downside is that it requires lots of mental and physical maintenance. This needs new batteries. The reservoir has to be changed every 2 to 3 days. The tubing has to be changed every 2 to 3 days, and the cannula has to be changed every 2 to 3 days. So it requires a lot more day-to-day maintenance than the standard basal bolus regimes. The advantage and the concepts related to that are that there's fantastic variation available in how you deliver the insulin. You can turn it up and you can turn it down. Background rate is delivered by a slow drip of rapid acting insulin at very low doses. That gives you a kind of a constant or relatively constant basal rate. If you're active, for example, if you go out for a run, a couple of hour run, you turn down your basal rate to cope with that. Whereas the previous basal bolus, once you've given your basal depot, that is impossible to undo. If you're resting, or if you're sick, or if you're taking steroids, for example, for fetal lung maturation, we can crank up the basal rate. The mums can crank up their basal rates. The boluses are on demand, but in the classic situation, they require a patient trigger unless they're looping. And I'm going to come back to where we are with looping in pregnancy. So if you eat, you turn up the bolus, and you can have any number of shaped boluses. You can have a simple curved bolus. You can have a square bolus if your absorption is delayed, for example, in pregnancy, or you could have a peak with a shoulder on it. So one of the big advantages of the pumps is that we can compensate for the pregnancy-related changes by different basal and by different bolus rates. And if you're running high after your meal, or unexpectedly high, as typically is the case for women with type 1 diabetes, you can have a small correction bolus. And with a pump, you can bolus from 0.1 of a unit up until 10, 20, 30 units. So the range and the flexibility is dramatically better than the traditional basal bolus delivery systems. And the next step came along the continuous glucose monitoring, or sensor augmented pump therapy, SAP by some. So you have a glucose sensor, and you've all seen patients now with Libra sensors on their arm, but there's a whole range of other interstitial glucose sensors which typically sit on the abdomen, and they link to the pump. Sometimes glucose monitoring is still needed to calibrate the sensors. Those, the Libra and the Dexcom sensors, are now available and don't need calibration, which is a big positive factor for people who are living with diabetes. The fact that they don't have to calibrate, they don't have to do CPGs, which are awkward, inconvenient, and socially embarrassing. So with the sensor, there's a little interstitial needle that sits in the interstitial fluid and detects the glucose level. This is not a capillary blood glucose. In this kind of system, this needle sends it to the transmitter sends it to the pump can alarm. Either the pump or the transmitter talk directly to your phone. They don't have to go through the pump, and then the alarm provokes action. As I've suggested with the Libra, you have a monitor where you can either use the provided monitor, or you can now use your phone, and you have to swipe the monitor on your arm. So this is slightly different. This has got a transmitter. The Libras do not have transmitters, and requires a human action to detect the glucose as well as the subsequent action. You can see this in either way. If there's no alarm, there's no nagging. And one of the things that wears people out with diabetes is the constant reminders from their systems. One of the things that can wear out people with diabetes is the constant feedback from their alarming, from their glucose sensing systems. So all of that is doable and useful, extremely useful in pregnancy. We recommend now that all women with type 1, and at least some of those women with type 2 diabetes, have a Libra or continuous glucose monitoring. And in Southampton, we like the Libras. They seem to be the best value. The Libra software process works well, and we can see the glucose trends over the internet. So all women with type 1, some women with type 2 are now recommended to have continuous glucose monitoring. Some women will come with a pump, and occasionally we start women on pump treatment in the pregnancy. But as suggested, it does require a lot of maintenance and engagement from the patient, and not all patients find it agreeable. So the next step is the closed loop, and this is what's called looping. And again, we're seeing some fantastic preliminary results from looping in pregnancy. And this involves the fact that the glucose monitor speaks to the pump, and so that the pump makes its own adjustments without any human interaction. And as you can see, this is a publication nearly 5 years ago now of the first preliminary data on looping in pregnancy. The biggest challenge for people with diabetes on insulin is overnight. So this is, where are we overnight? So this is midnight coming in here to the early morning. And you can see that when you have sensor augmented pump therapy, so the pump makes adjustments when you're asleep, it improves your glycemic control. So this is your typical glucose levels. In the closed loop is on the red, the sensor augmented pump therapy, so that's the standard sensor, but without looping, is in the blue. So the blue is a normal continuous glucose monitoring and pump, but the patient, the mother, adjusts the pump levels. The stuff in the red is the closed loop, where the machine, the computer, the software takes over the control of your diabetes. And you can see there's a significant difference in control I haven't showed you all the results slides from this paper, but the time in range, which is one of the markers we use to assess glycemic control, was significantly improved by looping. And there's a number of companies who are rolling out their own software which is freely available on the over the internet, and you just need a bit of technology to kind of link that all up. This is a very bright future for the management of glycemic control for people with diabetes, and certainly will have some significant advantages, I believe, for the management through pregnancy. So that's been a little bit of a whistle-stop tour through diabetes in pregnancy. I wanted to change tack a little bit and use the two examples that scare the mothers dramatically, and they scare the clinicians, of stillbirth and shoulder dystocia. And to spend a few minutes just talking about human factors and bias in decisions, and my most recent concept that of course risk is a color, not a number. So if you go to Mentimeter, the code is 5743697, and the question I'd like you to answer: would you gamble on the flip of a coin? If it's tails, you lose £100, and if it's heads, you win £150. So the question is, would you accept, would you entertain, would you go forward with that gamble? And I'm just going to have a pause for a second, and I'll hopefully the technology, I can see you all voting. Let's just have a look, see where that's going. No. Oh yes, good. I'm not going to show you the results until we've finished the rest of the slides, but okay. So I wanted to introduce you to ways of thinking. I'm sure some of you will have seen these before. I really hope you've seen these and understand these before, but they are so relevant, and it's just become apparent to me quite recently how everything that I do, everything that everybody else does, is influenced strongly by our different ways of thinking. So Daniel Kahneman wrote a fantastic book, which I'll mention at the end, and he talked about system 1 and system 2 thinking. So system 1 thinking is quick and easy, powerful, automatic, and intuitive. It's the stuff you do when you look out the window to see how far the car is away. You can see where the source of the noise is, and you can look directly at it. You can finish simple terms, Peter and Jane, war and peace, and you can solve easy mathematics without engaging anything more than a cursory thought process. It's how we drive on the road and listen to the radio, and how we drive on the road and have a conversation. It's all system 1 thinking, quick, easy, powerful. And it's how we survive in the modern world, because we can't be thinking long and hard about the risks and the balances of all our decisions. They're all done automatically for us with system 1 thinking. It's about running new information down existing pathways, and rather than developing new patterns and answers for each new experience. And it's, as I suggested, it's nice, it's easy, it's our lazy bit of brain. We don't have to apply much effort. Now the downside is that it has a significant risk of bias, and those bias lead to very predictable errors. System 2 thinking, this is slow and harder. It's deliberate, it's careful, it's cleverer, but we don't like doing it because it's such hard work, and so we try to avoid it. It's like Mr. Spock on Star Trek. Complete logical approach to answers and challenges. it requires a lot of mental effort, or a lot more compared to system 1 thinking. So for some of us of a certain age, recalling our mobile number it starts to involve system 2 thinking. Difficult parking, three-dimensional gearbox arrangements, lights arrangement, will my car fit in there, how can I get it in, etc., etc. Involves system 2 thinking. Solving more complicated calculations, including mathematical ones, are all about system 2 thinking, which is about creating new thinking processes and pathways. And this type of thinking leads to random, unpredictable errors. Cognitive biases are a systematic deviation from rational judgment. We all have them. They're mostly normal, and based on this kind of social reality, which is based on our own personal perceptions rather than fact and objective detail. All of our interpretations of the world around us, the green I see on the screen is different from the green you see. It's rarely objective. Rarely would we see the same situation in the same way, rarely if ever. But that interpretation, that personal perception, dictates our behavior much more than we imagine. We make stories to fit what we think we see or what we believe, rather than accepting the facts and the objectivity of what we think we see or believe. And we make assumptions based on these misconceptions rather than fully rational, logical thoughts and decisions and behaviors. So because of all that, we value losses more than gains. Our subjective bias is away from losing anything. We we make the losses much larger than the potential gains. And we overestimate, because of that, we overestimate the probability of unlikely events. Coming back to the shoulder dystocia and the stillbirth, we overestimate how this is going to come, both the women, the parents, and the clinicians. And we overweight unlikely events in our conversations and in our decisions about what's the best thing for what's the best time for your birth and what's the best method of birth. There's a strong tendency, quite a strong tendency, to avoid risk if we're winning. If we're ahead, we don't like to gamble. But if we're losing in any type of situation, then we have a tendency to risk and to take gambles. So, as I've suggested, these big losses of stillbirth and shoulder dystocia are very big, powerful numbers. If you think about the suicide bombing and the Novichok Salisbury experience, what were the chances of getting Novichok poisoning in Salisbury? They were virtually zero. They made no difference to visiting Salisbury, made absolutely no difference to your risk of Novichok poisoning. But the tourism in Salisbury fell off, reduced dramatically, because people were scared of this vivid and difficult disease caused by the Novichok. We pay huge amounts to insurance companies. That's why they're so successful. We pay to avoid the risk of losing the house, the car, something that's very valuable to us. On the other hand, is the lottery tickets. The dream of winning creates an extreme possibility effect. And Daniel Kahneman and his colleagues were able to calculate how big this effect looks. So on the top line is the actual chance, the objective chance of an outcome. On the second line is how it feels subjectively when we ask patients to think about a 1% risk of a really poor outcome. Well, it feels as big as 6%. And this is the possibility effect. As I've suggested, unlikely events, threats, grossly overrated. Stillbirth and shoulder dystocia. And at the other end is a certainty effect, where a 2% chance of not winning becomes grossly exaggerated and is felt as a 13% chance of not winning. So unless I tell you that there is no risk of shoulder dystocia or stillbirth, unless the risk, we want to be here, we want to be in the 100%. 100% feels like 100%, but as soon as you start creating a little bit of uncertainty, that becomes grossly exaggerated. 8%, 13%. Very interesting influence of our subjectivity and our bias in these numbers. Other common biases: anchoring, when we rely too much on typically on the first bit of information. It doesn't have to be the first, it can be any bit of information. We get it fixated in our minds, it agrees with our preconceptions, and we struggle to move on from that when we receive further information. Clinical example we had recently in Southampton: a mother with diet controlled gestational diabetes had a glucose after birth of 4.5, so completely normal. She was found unconscious. The normal resuscitation proceeded without much change to her condition, couldn't work out what was going on, and the teams had overlooked the possibility of hypoglycemia because they believed that gestational diabetes, that she had gestational diabetes and there was no risk of hypoglycemia. And actually, it turns out that her gestational diabetes was actually required insulin, which was not stopped at the birth. And again, there's an error of omission, there's a human factor there. And we were anchored on the fact that she was not on insulin. Diagnosis was hypoglycemia. A CPG might have helped, would have helped. Confirmation bias. This is what the facts say over here. This is all the science, all the subjectivity. And what happens is that we undervalue the vast majority of this stuff because it doesn't agree with our beliefs. And it leaves us in a rather foolish position. And we overvalue the bit of the facts that agrees with our beliefs. So we overvalue what agrees with our pre-held ideas and beliefs. The availability bias. This is all the information about a clinical situation. The information you use to make a decision is recent, frequent, extreme, vivid, and negative. These are all strongly influence the bit of the total information that you recall and use subsequently. Okay, so let's have a look at the gambling. I'm going to try and let's go for a new share. I'm going to go a new share. Where has that gone now? Okay. So you can see the results. Would you gamble on the flip of a coin?
We can't, sorry, Matthew.
Okay, so, okay, well, let me come back to my slides. I'm going to tell you now that 76% of you,
we can see them now.
yeah, okay, good, it's come through. So 76% of you said no. Why is that? Well, it's because 76% of you didn't want the fear of losing, whereas any logical explanation would be, on balance, you're going to win more than you lose. If you flip the coin 10 times, if a group of you all entered the competition, on average, you would gain more than you would lose. But because we fear loss more than gain, the results are quite consistent with the work by Daniel Kahneman and the bias that influences all of our decisions. So let's go back to my final few slides. Are you seeing the Gamble slide now?
Yeah, we're still seeing the. Are we just seeing your Menti, not your PowerPoint?
Coming through now. Counter risks of bias is where I am on my slides, and there's not many more now. Resume share. Still on Mentimeter?
Yes.
I'll keep on pressing new share and then PowerPoint. I'm going to, okay, what am I going to do? Let's go back there. Share screen. Okay. Not sure what you can see now, apart from nothing.
You're not sharing your screen now. That's back.
Great. Okay. Apologies. Okay. So ways to counter these biases: slow down, stand back, question, repeat, seek new information that challenges your current opinion. So go out of your way to seek information that you feel uncomfortable or doesn't agree with you, your way of thinking. Frame your diagnostic thinking to avoid premature closure, another bias that we've not talked about. Avoid labels such as preeclampsia. Better to use this patient was admitted with hypertension and proteinuria, or this patient was admitted with a high blood sugar. Talk about uncertainty with others at handovers and ward rounds. Go back and repeat the history and the examination and the tests. Ask for opinion without revealing your diagnosis or your thinking. Use computer-based assessment. So work technology into your clinical diagnostic thinking. There is a dirty dozen of human factors, and we mentioned earlier on the insulin that was prescribed after the birth, when normally we would strongly recommend it being stopped. And this is almost certainly due to distraction on a busy labour ward. But there's a list of human factors that affect us every day of our working and other lives. There are workarounds and some compensation processes for all of these. Given the pressure of time, I'm going to leave you to think about, and well, the first step is in kind of an awareness that human factors determine lots of our errors, lots of system errors, lots of process errors. Last concept: risk is a color. Everybody, and because the reason I've just outlined, sees the world differently, including risk numbers. And this is influenced by our personal and circumstantial details: fear, experience, previous birth, pre-held beliefs. Bright orange or cool blue, people can see the same color very, very differently. This was recently discussed in the BMJ. Alexander Freeman is the piece of work, which is short, and I'd recommend it to you. So as an example, The purple in the middle is coded by 6D46C4. And as you can see, the way we see the world around the exact same color makes it appear quite different. The way women and clinicians see risk is very different. And a number is a very limited, one-dimensional aspect to thinking about risk of shoulder dystocia, or of stillbirth, of indeed anything in medicine. And the more we step back and think about risk as actually as a color for the patient, the better we will understand what we should and might explain to them about that risk. So I'm going to skip that slide. So as I've suggested, Daniel Kahneman, Christmas is coming. This is a fantastic book. It's a bit of a weighty tone. I'd recommend it to you, but it does go into in a lot more detail how all the research that went into starting to think about how we think about risk and the human behaviors that determine much of our thinking. This was on the TED interview, and again, I'd recommend that to you. Don't trust yourself too much. Always be cautious, always stand back. What else could this be? Why am I thinking like that? Don't trust in ideas and beliefs just because you can't imagine an alternative. Stand back, think of an alternative. What else could be happening? Overconfidence in your beliefs, not in an arrogant way, but a belief in a system, a belief in a diagnosis, is the enemy of good thinking. The other way to counter this is and I love this mnemonic, is to spit the diagnosis when you think about something in medicine. What diagnosis is the most serious, probable, interesting, and treatable? Because this forces you to stand back. What is the cause of the chest pain? What is the cause of abdominal pain? What's the most serious thing I can think of? What is the most probable? What is the most interesting? And what is the most treatable? So it's a way of, again, countering our natural bias. That's it. I've finished. It's been a great pleasure. I hope that's been of some use to you on your medical travels. Thank you again for the invitation.
Thank you so much, Matthew. That was very interesting, and I'm sure some very good points about considering communicating risk to our patients and thinking about it. So just a few questions here, quick Q&A. So what is the reason behind women getting type 2 diabetes after having gestational diabetes?
I don't think there's anything unusual about pregnancy that leads to type 2 diabetes. It's much more likely that the predisposition to the diabetes just continued on before the predisposition that was there before continued on beyond the pregnancy. And there's obviously a possibility that they may have had to undiagnosed a glycemic leaning, if you like, that was undiagnosed before the pregnancy. So hence is the recommendation for lifelong glycemic follow-up and lifelong intervention to reduce that tendency.
Okay. Our next question is, what are the clinical priorities going forward for improving management of diabetes in pregnancy?
Good question. The clinical priorities, I think the rollout of technology for the pre-existings, so a better way of monitoring, and we've recently been able to prescribe Libras for all women with type 1s. I think we should be able to prescribe that for a bigger group. I think the use of technology for the women with gestational diabetes is a big priority. We don't have a good screening test for gestational diabetes. There's much uncertainty about whether we should be using a GTT or a fasting glucose or a glycosylated hemoglobin. And that's been further confused by COVID restrictions on GTT testing. You're probably aware that many hospitals have abandoned GTT testing and are using just a random or fasting glucose and a glycosylated hemoglobin. perhaps we should give women with gestational diabetes a Libra, and they just plug it in their arm, and they just carry on with their normal diet, and they swipe, and we see their results distantly. It would be much more convenient than a GTT, which generally women do not like.
And do you see that being rolled out as, you know, kind of a common occurrence in the next couple of years?
Yeah, I think we're currently researching it. So there's a big study looking at what is normal CGM monitoring before we can decide what is abnormal, and before we can link the abnormal levels to outcomes. So there's a few steps to do, but that, I think, is a direction of travel, and I think that's a sensible direction.
Mm-hmm.
Make the monitoring easier, because doing CPGs is a pain in the bottom for most women. 6 times a day they have to prick their finger, they can't get on with their work, there's blood gets everywhere, they have to carry lots of, you know, all the paraphernalia that goes with. So it's not a very convenient way of monitoring. The Libra is magic when you ask women how did they find the CPGs, and now how do they find the Libra? They always smile.
And that's what matters to us, I'm sure. And maybe one or two other questions. So this next one is about the risk part of your presentation. So how do you think we can best approach counseling patients for treatment to avoid exaggerating risks and biases to them?
Yes, yeah, that's a fantastic question. I think there are many techniques that we need to think about. I don't have those to hand, but the first step is to think about what do I believe here? Is that consistent? Is that objective as possible? Ask the patient, what do they see is the risk? Some women don't worry about the normal birth of large babies at all. They had a 4-kilo baby last year and the year before, and you're telling me this baby's going to be 4 kilos again? Well, I'm not in the slightest bit worried, because my previous experience was very positive. So there's not much point in talking to them about shoulder dystocia, because they perceive that risk as much smaller. So be guided by the patients, by the women.
That is,
Numbers. I think numbers are useful but potentially misleading.
I think that links brilliantly into our next speaker, Emma Doble, who has got type 1 diabetes herself, as well as a very impressive background as the editor of BMJ, and also the consumer coordinator of Cochrane UK. And Emma herself has had a baby boy back in April at the start of UK lockdown, the first one. So I'm sure we'll all be very excited to hear from Emma and her experience.
Thank you so much. I was going to just share some slides here for you.
Can you stop screen sharing, Matthew?
I can, yes, certainly. I just had a question for Emma. I mean, she would be best placed to answer the question about how does she see risk? I mean, she's the one with the experience. It's not a disease, you know. The pregnancy. I'd be very interested in if I can steal a couple of minutes. I'd be very interested in what Emma thinks about the thoughts on risk. I don't know whether she was listening into some of my things, because doctors are notoriously awkward about sharing power. And when you say to the patient, you're in control, you tell me what you think is a big risk, that is a power surge from the doctor to the patient. And we haven't historically done that very well.
Yeah, definitely. I think the whole topic of risk and the communication of that, I do a lot of work in kind of communicating with patients, and it's a difficult balance, because on one hand, as a patient, I want to know and be aware of everything that I'm at risk of. Of course, I don't want to have that surprise kind of thrust upon me because I've not been informed. But there's also a delicate balance when that's communicated. And I think I found, certainly with my pregnancy, being told of these, horrible outcomes when I was already pregnant was horrible, because by that point you sort of felt like you were kind of too far down the track to really do anything about it, or to really kind of ingest that information objectively, because I was already pregnant and there's already that emotional connection. So I was very lucky and had a lot of preconception counselling, and for me that was the perfect time where we had those very open discussions. I think with risk, the best thing to do is to just be very open and very honest, but also just ensuring that that's done at the right time, because I think timing is so critical if you want patients to really take that information on and really ingest it as well, rather than just it kind of thinking this is too much and I don't want to think about this right now. So yeah, timing.
Timing is everything. I like that.
Yeah.
Explaining to women after their pregnancy about contraception and breastfeeding and annual checking and this and that and blah blah. That is bad timing.
Yeah, absolutely.
Emma, I'm looking forward to your presentation. Sorry to have eaten some of your time.
No problem. Thank you. I'm just going to check that you can see my slides okay.
Yeah, we can see them.
Perfect. So yes, so thank you so much for inviting me along to speak at this seminar. I think it's really is a great kind of initiative that you have both healthcare professionals and patients speaking together on topics like this, because I think having both perspectives is really important when we're talking about things like type 1 diabetes and pregnancy. So a little bit of background about myself. So I was diagnosed with type 1 diabetes at the age of 4. And I think being diagnosed that young, you really don't have any concept of what's to come. And I think my life anyway, has always been type 1. I don't know any different. So in some ways, I think that's maybe a positive thing, but it's definitely had its challenges. And for me, growing up with type 1, I found it really, really difficult to learn how to live with my diabetes and how to accept my diabetes, particularly as a teenager and in my early 20s, which is probably not surprising. I think I started to develop complications when I was at university, and really kind of disengaged completely from the health service, because I just felt that I was just getting a telling off every time I was there. I kind of took some time just kind of getting my head around having type 1, and I was always pushed to try an insulin pump, and had been from around about the age of sort of 12. And I was really against an insulin pump. To me, a pump meant that I was attached to something. It meant I couldn't ignore my diabetes. And it just felt like something that meant I was going to have to tell everybody I had type 1, which was just a horrible thought. So it took a long time for me to get to the point where I felt that an insulin pump was helpful for me. And my main motivation for that was knowing that I wanted to have children. And I think knowing that kind of was my sort of persuasion into learning how to manage my diabetes better. And I think for me, diabetes has always been a balance. I could have perfect control of my diabetes all the time, but that would mean that I couldn't do anything else with my life. And it's a real challenge to find that balance of living the life that you want to live and also being healthy in the best way possible. So just a little bit of context on pregnancy and diabetes, and I think Matthew gave you a really good kind of insight from the healthcare professional's perspective. But I think from a patient perspective, it's really important to know where we might be coming from when we come to our first appointment in terms of pregnancy and diabetes. So I was always worried about having children. Even as a teenager, it's something that my healthcare professionals, so my diabetes team, really put down to be a negative thing. I was constantly told, please don't get pregnant. And I totally understand that my diabetes management was not good, and it therefore would not have been a good time to get pregnant. But that feeling stays with you, and it really becomes something that you worry about. You hear of the kind of all of the very negative aspects, and that kind of idea of having high blood sugars and all the risks and all the challenges was something that certainly worried me growing up. And you always have that pressure of having that sort of perfect diabetes management. And I always felt that when the time came that I was wanted to have children, that I was literally going to have to just do nothing else but manage my diabetes in order to get it to a level that would allow me to have the most risk-free pregnancy and delivery. And I think for me, it was a real balance in getting to a point where getting that timing right for putting my diabetes management at the forefront, but without burning out. Because I think the idea that you want to have the best diabetes management before you get pregnant is really difficult in terms of working out your timings. And you don't want to get to a point where it's, burnt you out, and it's, because it is hard work. So where did I start? So I was initially given some preconception counselling, and I had this probably around 3 years ago now. And I spoke with my diabetes team probably for the last 5 or 6 years about pregnancy. And they've always said to me, before you decide to get pregnant, you must come and do some training and have some support and some discussions around pregnancy before you even consider getting pregnant. So when I knew that that was something that I definitely wanted to do, I definitely wanted to have children, I went along, and I had a couple of sessions with a diabetes specialist nurse. And a lot of that was just around telling me how to kind of manage my diabetes in the best way. And a lot of what I did for probably 6 months to a year was actually just playing around with my diabetes and playing around with different foods, different insulin, using my pump in different ways to get to know my diabetes and my body better. Because diabetes and patients, we're all very different. And I think although the textbook or you might see one patient who experiences something one way, we're all very different, and how we all cope with our diabetes is very different. So having that chance to kind of have a little bit of pressure off, but to also really learn about how my body reacted to different types of carbohydrates, sugars, exercise, and the different types of insulin bolusing and that Matthew explained to do with your pump was really helpful for me. I also started to have some discussions around my main worries, and this really links well with Matthew's points on risk, because before I'd ever gone into my preconception counselling, I was aware, well, my feeling was that people with type 1 would only ever have to have a C-section. There was no way that I was going to give birth naturally. And I think that was largely down to the fact that we were always told you'd have really big babies, and that was something that, within my first conversation with the diabetes specialist nurse, her telling me that no, that wasn't the case, and I could absolutely give birth naturally, assuming that happened, was hugely helpful for me, just to know that I had options. And also around the impact of high blood sugar. So as Matthew's explained, I was aware that there was definitely some risk of high blood sugars, stillbirth, miscarriage, and babies being too big. But I think just having a really open conversation around what that actually looked like, because to me, high blood sugars were a very common thing. All of our blood sugars naturally go up when we eat. And I think that understanding a bit more around just the science and the biology of how my body was reacting and how that might affect the baby was really helpful. And I also just started doing some of my own research and found the JDRF pregnancy toolkit was one of the most useful resources, because it was written by other patients who had type 1 who had babies. So I found that really reassuring, because I think often we only hear the negatives, and it's really important to hear some of the positives as well. So in my first trimester, I found out I was pregnant, and often, well, I think whenever I was talking about pregnancy with my healthcare professionals, they just told me that as soon as I had my positive test, the first thing I was to do was to phone them. They often joked before I phoned my husband, but luckily he knew before my diabetes team. But I contacted them as soon as I found out, and instantly, as soon as I had that test, I started to worry about having high blood sugars. And I think that's maybe not not surprising. It's something that had always been in the back of our minds. And I think that kind of context around pregnancy and type 1, that's the thing that we were always told: high blood sugars equals problems. I found that I was really overthinking about my food, about my insulin, about my blood sugar levels, and I was becoming really anxious around it. Matthew said earlier about taking 6 blood sugar tests a day, 6 finger pricks. I was probably taking that every couple of hours. I think that's just the reality of having type 1 and pregnancy and wanting to be as healthy as possible. So that's when I decided to opt and get a constant glucose monitor, so a CGM. And I have to be honest, there's pros and cons. For me, the positives was being able to see my blood sugars and being able to see how some of my patterns, because I think that was really difficult to see when you're so deep into managing your diabetes every day. But what it did also mean was that I ended up having a huge number of hypos. And that's purely just from watching a line creeping up. Having that fear of high blood sugars instantly meant I was going to start overtaking more insulin than I probably needed. So I've put up here a picture of, this is my CGM on my phone during my first trimester. And you can see that within a 24-hour period there, I've probably had 2 or 3 hypos, which is not great. And I was somebody that before pregnancy was probably having 1 hypo every couple of months. So you can imagine that this was quite a big difference for me. I also started having lots of hospital appointments and lots of scans. And I think from the minute you're pregnant, you're instantly in a healthcare system, and it becomes a very clinical operation. I think the excitement of having a baby and having that idea of becoming a mum was not there at all. I think it was really very much about the clinical aspects from day one. My second trimester was probably a little bit less exciting, I think probably for most pregnant people. By that point, I'd kind of settled into my diabetes a little bit better. Working with my diabetes midwife and consultant, really my main focus was trying to reduce the number of hypos whilst also managing my concerns and worries about having high blood sugars. And I've put up another picture of my CGM graph, and I really want you to focus on the kind of overnight, so the right-hand side of this graph. And often in diabetes, we talk about having this flat line and having, really good blood sugar control, particularly in pregnancy. And that line, which does not look flat in the slightest, is actually quite flat for an overnight blood sugar. So I just really wanted to kind of highlight that. I think often when we as patients put this pressure on ourselves to have a perfectly flat line, and actually when you look at it on a CGM, it doesn't necessarily look like how you think it might look. So it's just really important to think about that. Going into my third trimester, I think this was really where the hard work began. And up until this point, I hadn't had any morning sickness. I'd felt quite well, to be honest, other than all of the hypos. And I hadn't really noticed any major changes in my insulin requirements. And we'd had lots of conversations leading up to my kind of third trimester that at some point my insulin requirements were going to go up. I was going to need more insulin. And I think it's a bit of a waiting game. You're constantly waiting for that day to arrive when you all of a sudden need more insulin. And I definitely did notice huge changes in my insulin requirements in my third trimester. And I found that really difficult to manage, because learning about diabetes in your body and what it does is really is a lot of work. And just when you think you figured it out, something happens and it completely changes again. And I think trying to figure out my body and my insulin whilst being, really far into my pregnancy was just really worrying for me. So I then upgraded my CGM to, as Matthew was saying, around about this closed loop system. So what that meant was that I had my CGM would talk to my pump, and that really helped me with the number of hypos that I was having, because even though we're all told that insulin requirements will go up during pregnancy, I found that my insulin requirements overnight dropped significantly. And during my final few weeks of pregnancy, I was basically having no insulin overnight because my pump was suspending it and I was constantly hypo throughout the night, which is not unusual, but it's definitely not what we're all told to expect. So that having that suspend and that kind of connection between my CGM and pump was really useful. And you can see there that on my pump, you can now see the lines that I was seeing on my phone were now connected up. So that was now one system. I did also notice though that during the day, my insulin requirements did go up. So I found it really difficult to eat carbs. It was just a real minefield to try and balance getting the right insulin at the right time, because the timing of my insulin was becoming impossible to manage, having to have my insulin so far in advance from meals in order to catch the carbohydrates pushing my blood sugars up, but also avoiding that hypo if I didn't eat perfectly at the right time. So it was definitely hard work. And I started at this point to really work with my diabetes team and midwifery team around about my birthing plan. And I'm going to give you a bit more detail on that in a bit. And we also, again, discussed more of the issues that my baby might face. So up until this point, other than the preconception counselling, we hadn't really spoken about my kind of what might happen to my baby when they were born. So we had a tour of the hospital and went to things like the special care baby unit just to give us a sense of, so that it wasn't a surprise if that potentially happened, and just knowing what all the options were and what might happen for us. So I just wanted to give you a little insight into my birthing plan. And I think the main reason I wanted to show you this was just to show how complicated it is, but also how simple it can be. So I had a huge number of people involved in my birthing plan. We had all of our diabetes specialists, we had all the midwives, obstetrician, my GP, and I think the main people, and the reason I've put us at the top, my husband and I, is because we were involved. We were the only constants throughout this whole process. And I think it's really, really important to remember that there is a woman and a baby and a partner who are at the heart of everything that you're doing, and particularly with birthing plans, because often the team will change and circulate around you. And I think it's really important that patients and mums are involved in those birthing plans from the get-go, really, and they really have to have the ownership of them, because they are the ones who are going to turn up to the hospital and have to communicate a lot of this often to the teams when they come to giving birth. We talked through various different birthing scenarios. So what would happen if I had an induction? What would happen if I had a C-section? What would happen if I just had a natural labour without having an induction? And all those different options. We spoke about different pain relief options. Often patients with type 1 diabetes find gas and air gives them the same sense of feeling hypo. So I didn't want to go down that route. I wanted to be able to know whether my hypo was because I was hypo or because I was taking gas and air. So I think it's really important to have those conversations and think around how those things might affect insulin and type 1 diabetes. The main thing for me was thinking about how my diabetes would be managed through all those different birthing scenarios. And I was really keen and really passionate that I wanted to keep my pump and I wanted to keep control of my diabetes management throughout my birth. And this became a real sticking point between me and my team, because my team were really keen that they wanted to take control of my diabetes. And we had a lot of back and forth with me saying it was my diabetes, I manage it, I know it better than anybody does. And I wanted to make sure that I had full control, because I would know much more than any healthcare professional would know. But my diabetes team felt that I had never given birth before. That was something new for me. And therefore, they wanted to make sure that they could manage my diabetes and I didn't have to worry about it if things weren't happening the way that we wanted or hoped. So we eventually came to an agreement between us that if I had 2 blood sugars above 7 millimoles, so above, in that kind of higher range, that then I would allow them to sort of take over. But up until that point, they were to support me in having my pump and managing my diabetes myself. So it was a long conversation, and it took a lot of back and forth, but we found a compromise, and I think that's really important. There was also some discussion around who would lead my diabetes management, particularly if I'd had a natural labour. I probably was not interested in managing my diabetes throughout the final stages of a natural labour, but I really trusted my husband to do that rather than a healthcare professional. So we made sure that that was all noted. And we had these kind of agreed points on our plan. And I think maybe the most important thing was knowing how this was communicated. So we had all of these notes were included within my maternity notes. So they went everywhere with me, and I had full ownership of them to make sure that I was the one that was able to communicate this when I turned up to the hospital for my labour. And I had written my 3 top key things that were important to me on the very front of this book, because I wanted to make sure that those things were noted by everybody. Anybody that touched my pregnancy notes were aware. And those things were keeping my pump as long as possible, and making sure that I wanted to breastfeed, and that I wanted to have a natural labour as much as possible, if possible. I had a copy, and my team also had copies as well at the hospital. So in terms of my delivery, I had gone in for a planned induction. We opted for a planned induction as a joint decision between my healthcare professionals and I, as we were in the height of COVID-19 and the pandemic. And if you remember, at the beginning of the pandemic, diabetes and pregnancy were 2 of the areas which were of huge concern. And we had a conversation to say, is my baby healthier in or out? And we decided when I was 38 weeks that it was probably better for baby to be out. When I arrived at the hospital, had felt a huge amount of pressure from the doctors there to just opt for a C-section. And I think that was really difficult. We kind of pushed back a bit. I think they were just really worried about managing me having type 1. During my final few scans, so my baby throughout my scans had been perfect, no problems. In the final few scans, they had found, well, they thought that my baby was getting quite big. So they were worried about that. And I think they were also just worried about COVID-19. So they were really pushing for a C-section. And eventually, about 14 or 15 hours into my induction, my baby's heart rate was dropping quite significantly. So a very quick decision was made that I would have the C-section. And during my section, I managed to keep my insulin pump on the entire time. And with the use of my CGM and my pump, I managed my diabetes myself during the C-section and throughout my recovery as well. So that for me was really good that I was able to do that, and was, even able to reduce my background insulin at the beginning of my C-section to prevent a hypo, which was great. And I delivered a very healthy and a very normal weight baby. That's important to say. He was not any bigger than he would have been had I not had type 1 on the 10th of April, and very early in the morning. I just wanted to touch very quickly on the 4th trimester. I think it's really important. It was probably the most difficult part of my entire journey with pregnancy. I found that my insulin requirements reduced significantly after giving birth, particularly breastfeeding, and all of my focus went onto my baby, and my diabetes basically just carried on in the background, doing very minimal with my diabetes management. And I think due to COVID-19, we have not really had much kind of any of the planned follow-up care or support. And I've written about this in our BMJ opinion series. If you have any interest in knowing a bit more about my kind of post-birth experience, please do have a look at that. So in terms of our key messages, I just wanted to highlight a few things that maybe you could do just to help people like me going through pregnancy and type 1. I think the first thing is just don't be afraid to ask questions. We have no expectations that you are an expert in any in diabetes, please do just ask us, and we want to work with you as a team. We want to be part of the team with you. I think communication is key, making sure that any preferences that we've discussed with you are at the heart of what you're doing. And if any changes have to be made to that, then please do communicate that in a kind of respectful way. I think giving patients ownership of their notes, but also of their entire journey, and make sure that we're part of the team. We want to partner with you. We don't want to just be told this is what's happening and this is what you're doing. And I think the final thing is just that there's no such thing as perfect diabetes management. And I think as soon as we all accept that, it makes living with type 1 and also managing type 1 during pregnancy in particular much more easier to manage when we're not trying to achieve this goal, which is just not existing. We are all doing our best, and I think that's all we can really do for us and our babies. So thank you so much, and I'm really happy to take any questions.
Thank you so much, Emma. So we have time for a few questions, if you don't mind. I know we're running a bit long. So do the aspects of diabetes and risks during pregnancy affect your mental health at all?
I don't know if it affected my mental health in a very explicit way, but I think it definitely made me feel very anxious, and I was definitely very worried. And I think most people who find out they're pregnant probably have an element of that worry and anxiety about what might happen. But I think maybe just with having type 1, you're just so much more aware of everything that can go wrong. You know, you've had those conversations around everything that can go wrong and how likely that is to happen. And most people who are pregnant haven't had that conversation necessarily. So I think it was definitely worrying and a lot of anxiety. Yeah.
And then another person asks about how were your blood sugars impacted by breastfeeding?
Yes, so my blood sugars were impacted quite a lot. So I was constantly hypo. I think I have some friends who have type 1 and they've also had shared that with me, that breastfeeding would mean just literally breastfeeding with one hand and eating jelly babies with the other. And I think that's exactly what breastfeeding with type 1 looks like in a picture.
Okay, then this is an interesting question. Were you able to speak to other women who have been in your position? And if so, did this help?
Yes, definitely. I was very lucky that I have a few friends who have type 1 who'd also had babies, and also I think using Twitter was really nice to be able to connect with other mums with type 1. And normally my hospital that I go to would have mums meeting up together after you'd given birth as well, who'd all have type 1, and that's obviously not happened with COVID, but I found that that's really helpful. I think that's where you learn the kind of practical aspects and the real life aspects. I think healthcare professionals can tell you the facts and the figures, but speaking to other people really tells you what you need to know.
And then perhaps one of our last questions was, why did you feel so strongly that healthcare professionals shouldn't be involved in your diabetes management? I assume this refers to during birth.
Yeah, I mean, I think this goes back to, I've been an inpatient for a couple of things before. And often when you're an inpatient, the healthcare professionals that are dealing with you are not necessarily experts in diabetes. And I think diabetes is a really complicated condition to manage. I know when I'm going hypo, I know how food affects me, and I know how when I need to take my insulin and the timing of that. And I think I felt like if I handed all that control over to a healthcare professional, then I was going to be I would find it very difficult to really be able to kind of switch off from it. You know, I think diabetes management has been part of my life for every single day that I can remember. So if you all of a sudden, if you take that away from somebody, I think it's really difficult to kind of let go of that control. And then there's definitely that worry that the healthcare professionals aren't going to have that kind of knowledge and expertise that they need in practice, and because we're all different. I think all people with type 1 are different.
I think that's a really good point, and I'll definitely be thinking about that one. So this would be probably a good question to finish up on. So can you recall your most positive experience with a healthcare professional during your pregnancy and delivery? And if you can recall one as well, perhaps one that could have been improved, and how would you have liked to be different?
I think that's such a good question. So yeah, I had so many really positive experiences. I think maybe firstly with my diabetes consultant, where he really strongly wanted me to put in my birthing plan that healthcare professionals could take control of my pump. And I was really, as I said, really against that. And he, I think he really sensed that I was really worried about that, and he handled it in such a good way that he really kind of took a step back and said, okay, tell me why that's worrying, and what can I do to alleviate some of that worry. So it was things like, together we recorded all of my insulin requirements that I would have, and he made sure that that was available for all of the team to see and have that information. So it became, what was a kind of very difficult conversation at the start, became much more positive, because we really both kind of had to listen to each other, and he really acknowledged my opinion and my preference on it, but also was obviously trying to do his job and make sure that I was safe during the delivery. And I think a negative one, I think honestly, the difficult ones that we had were probably just post delivery. So we had a huge number of plans in place of what was going to happen with my diabetes management during the kind of first couple of days, because I knew that my insulin requirements would change significantly almost immediately after giving birth. And the team that I had on were not even aware, I don't think, that I had type 1 particularly. And all we really had was them just saying, are you okay? You've got, can you just get on with it, sort of thing. And I think they were just very nervous, didn't want to deal with my diabetes. So I think if they had just been open and said, look, we're not really sure what to do, but can you just tell us how we can help? That would have been just a little bit reassuring to know that we could at least go to them if I had questions about my diabetes in those few days.
Okay, I think we're going to wrap it up there. Thank you so much, Emma and Matthew, for a wonderful and insightful evening. For everybody, thank you so much for attending. So I'm going to stick around for a few minutes if anybody's got any problems with the feedback form.